Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session I will be discussing a very important topic in the cardiology, that is the restrictive cardiomyopathy. So if you see the definition of this restrictive cardiomyopathy, it is the disorder in which the heart suffers from the diastolic dysfunction. So it is the disorder which is characterized by diastolic dysfunction. So why is that there will be diastolic dysfunction in these patients with the restrictive cardiomyopathy? See, in these individuals, the walls of the ventricles, they become stiff. Right? In this individual, the walls of the ventricles, they become stiff. And not only stiff, they are also thickened. Right? Not only stiff, they are also thickened. Because the walls of the ventricle, right? Because the walls of the ventricle, they become stiff and thickened. That is the reason why these ventricles or this particular heart will resist the normal filling during diastole. Okay, so this will resist normal filling during diastole. That is what will happen in these patients with the restrictive cardiomyopathy. So the heart cannot relax normally during diastole. So it is unable to fill properly, right? But in these individuals with the restrictive cardiomyopathy, let me tell you, they have intact systolic function. Right? They have intact systolic function of the heart. And these patients with the restrictive cardiomyopathy, it is one of the rarest form of the cardiomyopathy. So we have three forms of cardiomyopathy. One is dilated cardiomyopathy, second will be your hypertrophic cardiomyopathy, third will be the dilated cardiomyopathy. Among these three, the most common is the dilated cardiomyopathy, and the rarest form will be the restrictive cardiomyopathy. Now, you need to know the etiology. What is the most common etiology causing the restrictive cardiomyopathy? The most common etiology causing restrictive cardiomyopathy include the amyloidosis. Right? It includes the cardiac amyloidosis. Now, what is amyloidosis? It is the disorder which is characterized by accumulation of abnormal protein. Right, characterized by accumulation of the abnormal protein in the various parts of the body. That is what is your amyloidosis. And this particular cardiac amyloidosis, let me tell you, this is more common in men rather than women. And the age group at which you will have this development of cardiac amyloidosis is around the age of 40 years. Right, around the age of 40 years. So now this abnormal protein which gets accumulated in cardiac amyloidosis, it could be a light chain amyloidosis or it could be a heavy chain amyloidosis. And particularly if you take light chain amyloid proteins, they are toxic to the cardiomyocytes. Okay, so the light chain light chain amyloid proteins, these are toxic to cardiomyocytes. right? These are toxic to the cardiomyocytes. And these light chain, they may also internalize into many cell types, right? They will internalize into the various cells and they will produce toxicity to the cardiomyocytes. And this may explain some of the cardiac dysfunction. So because these light chains, they internalize into many cells and that will be responsible for cardiac dysfunction, right? That will be responsible for cardiac dysfunction, okay? And this AL, that is light chain type of amyloidosis or AL type of amyloidosis, this is the most common type, right? This is the most common type, right? And among this amyloidosis, the cardiac involvement is around 50%, right? Among this entire amyloidosis, among the disorder of the amyloidosis, the cardiac involvement is around 50%. So that is about your light chain amyloidosis. Then we have, right? Then we have secondary amyloidosis. Secondary amyloidosis, it is due to fragments of serum amyloid A protein associated with chronic inflammatory disorder. So here what will happen is, so this is due to fragments of this is due to fragments of serum amyloid A protein. Okay, so the fragments of serum amyloid A protein, this is associated with chronic inflammatory disorder, right? So this will cause a chronic inflammatory disorder, and which is nothing but your secondary amyloidosis, and this is a rare cause of the cardiac disease. And we also have the other form that include mutated transthyretin, that is nothing but your familial amyloidosis. So what is familial amyloidosis? Familial amyloidosis is that where there is accumulation of mutated transthyretin. Right, mutated transthyretin. That is what will happen in the familial amyloidosis, right? And this transthyretin, right, this transthyretin, it is produced almost entirely in the liver, right? It is produced almost entirely in the liver. Which one? The transthyretin. And in familial amyloidosis, it is the accumulation of the mutated transthyretin, which is nothing but ATTR, right? Which is nothing but ATTR. Okay, right. Now, after having discussed about the amyloidosis, so the most common form of amyloidosis causing restrictive cardiomyopathy is AL type of the amyloidosis, that is light chain amyloidosis. Then what will be the treatment for this AL amyloidosis? You need to give the alkylator based chemotherapy. Right, alkylator based chemotherapy, or you need to give high dose melphalan. Right, or you need to give high dose melphalan, and this is followed by, right, this is followed by autologous stem cell transplantation. right? Autologous stem cell transplantation. So this will be the treatment for the AL type of amyloidosis. Whereas in immunoglobulin light chain amyloidosis, the treatment is standard or high dose chemotherapy with stem cell rescue is often pursued. So standard or high dose chemotherapy right, standard or high dose chemotherapy with stem cell rescue. Okay, so that will be the treatment for the immunoglobulin light chain amyloidosis. So the treatment for amyloidosis is the alkylator based chemotherapy or high dose melphalan, and that should be followed by the autologous stem cell transplantation. Then I said you about the familial amyloidosis. See, in case of the familial amyloidosis, it is the accumulation of mutated transthyretin, that is ATTR is your transthyretin. So in these individuals, the treatment that is effective or the medication that is being effective is tafamidis. Okay, so in 2018, the medication tafamidis right, the medication tafamidis was shown to be effective in the transthyretin amyloidosis cardiomyopathy, right? And this tafamidis substantially improved the survival of the individual. Right, improved survival of the individual, and it also reduced the hospitalization of the patient. Right, it also reduced the hospitalization, and it also improved the quality of life. Right, it also improved the quality of life for patients with transthyretin amyloidosis cardiomyopathy. So that is about your tafamidis. So tafamidis, it is the treatment for transthyretin amyloidosis cardiomyopathy, right? Then followed by that, in the treatment of amyloidosis, you have given the chemotherapy or you have done your autologous stem cell transplantation, but still if the disease is persisting, the last available option is the cardiac transplantation. So cardiac transplantation, it also has been used in patients with primary cardiac amyloidosis. Right? So in primary cardiac, right? So in primary cardiac amyloidosis, the cardiac transplantation has been found to be useful. Now, so the most common cause for your restrictive cardiomyopathy will be your cardiac amyloidosis. Then what are the other common causes? The other common causes include the radiation heart disease, right? The radiation heart disease. This radiation, it can lead to a mixed restrictive and constrictive pericarditis. And the other common cause, right? The other common cause include the myocardial fibrosis. Right? The other common cause include myocardial fibrosis after an open heart surgery. So this will contribute right? So this will contribute to the development of the restrictive cardiomyopathy. Now, see, these three are common causes: amyloidosis, radiation, and as well as the myocardial fibrosis. But among all these, the amyloidosis is most common. But apart from this, we also have some other causes which will cause the restrictive cardiomyopathy. That includes, see, we have a disorder which is characterized by accumulation of a non-caseating granuloma, and that particular disorder is sarcoidosis. So even this sarcoidosis will contribute to the development of restrictive cardiomyopathy. Then we have a disorder which is characterized by the infiltration or accumulation of iron within the heart, and that is nothing but your hemochromatosis. Right, so that is nothing but your hemochromatosis. So hemochromatosis is the disorder where there is excessive accumulation of iron within the myocardium, and that will make the individual to develop restrictive cardiomyopathy. Then we have another important disorder, that is carcinoid syndrome. So carcinoid syndrome, it is the disorder which is characterized by the accumulation of the 5-hydroxytryptamine or serotonin within the heart or within the myocardium. So that will make the individual to land up in restrictive cardiomyopathy. And these patients with the carcinoid syndrome, most commonly they are associated with tricuspid valve or the pulmonary valve dysfunction. Right, tricuspid valve or pulmonary valve dysfunction. And the other important disorder is the scleroderma. So scleroderma, right, scleroderma, it is a disorder of the connective tissue where there is excessive accumulation of the collagen within the myocardium. That is what will happen in scleroderma. Then we have a hypereosinophilic syndrome which will cause restrictive cardiomyopathy, that is Löffler syndrome. Right, so it is a hypereosinophilic condition which will cause restrictive cardiomyopathy. And then finally the other important disorder is glycogen depositions. Right, so these are the disorders which will cause the restrictive cardiomyopathy. Right, and we have a disorder which is a lysosomal storage disorder which will cause restrictive cardiomyopathy, and that particular lysosomal storage disorder is the Fabry's disease. So the question is, how does the Fabry's disease cause the restrictive cardiomyopathy? So first of all, Fabry's disease, it is a rare genetic disease. Right, it is a rare genetic disease, and it is the disorder which is characterized by deficiency of the enzyme alpha galactosidase A. Right, so the enzyme that is being deficient is alpha galactosidase A. Right, and this particular enzyme deficiency will cause buildup of a type of fat. Right, this deficiency will cause buildup of a type of fat, and that particular fat is called globotriosylceramide. Right, globotriosylceramide. So this fat gets accumulated within the myocardium, and that will make the myocardium thick and stiff, and thereby the relaxation of the myocardium does not occur. So, and this Fabry's disease, it is a type of a lysosomal storage disorder. Right, it is a type of a lysosomal storage disorder. Okay, that is what is your Fabry's disease. And then what will be the manifestations of Fabry's disease? So this particular fat, that is globotriosylceramide, is accumulated in multiple organs in our body. It is a multi-system disorder. So it gets accumulated within the kidney, causing reduced kidney function. and there will be also progressive kidney failure. And this globotriosylceramide that gets also accumulated within the nervous system, where the individual will have the neuropathic pain that is due to dysfunction of the nervous system, right? That is due to dysfunction of the nervous system. And this particular globotriosylceramide also gets accumulated within the eyes, right? And the appearance of the eye, they change, right? The appearance of the eyes changes. And this globotriosylceramide also gets accumulated within the skin, thereby the individual will develop dark red spots or rashes, right? And there will be burning or tingling sensations, and there will be also sensitivity to temperature and profuse sweating. So that will be the cutaneous manifestations in the Fabry's disease. And this globotriosylceramide also accumulates within the GAT, causing abdominal pain, constipation or diarrhea, and there will be also nausea. Gets accumulated within the brain or brain vasculature, resulting in the development of stroke. Gets accumulated within the heart, resulting in restrictive cardiomyopathy, and there can be also irregular or abnormal heart rhythm. And it also gets accumulated within the ear, resulting in tinnitus, hearing loss, and as well as the vertigo. So this will be the features of the restrictive cardiomyopathy, right? This will be the features of the Fabry's disease. So to summarize, right, so you can just use this mnemonic Fabry's. F stands for these individuals will have febrile episodes. A stands for angiokeratomas, and the enzyme deficiency also starts with A, that is alpha galactosidase A deficiency, right? B stands for burning pain, that is neuropathic pain. R stands for renal failure. Y stands for youth disease, in the sense it is seen in the young individuals. And C stands for ceramide toxicity, that is globotriosylceramide that gets accumulated. And last C stands for the cardiovascular disease. Okay, so these will be the manifestations of a Fabry's disease, which is a lysosomal storage disorder, which will cause the restrictive cardiomyopathy. Next, followed by that, which of the following is a cause for restrictive cardiomyopathy? Alcohol, hemochromatosis, amyloidosis, then sarcoidosis. Let me tell you, your hemochromatosis, amyloidosis, sarcoidosis, all these three will cause the development of the restrictive cardiomyopathy. But among all these, the most common will be amyloidosis. So the answer will be C. And you take this hemochromatosis. Hemochromatosis will cause restrictive cardiomyopathy, and hemochromatosis, it will also cause the development of the dilated cardiomyopathy as well. So with hemochromatosis, any of these can be seen. Now you see the next question. A 34-year-old male experiences shortness of breath with minimal exertion. Physical examination reveals elevated JVP markedly worse with inspiration and 2+ lower extremity pitting edema. The laboratory studies are normal. Cardiac biopsy revealed apple green birefringence with Congo red staining. Genetic testing reveals a mutation in which particular gene? Frataxin gene, transthyretin, ankyrin, beta-myosin gene, tropomyosin. So, presence, what is this disorder suggestive of? This is the disorder which is suggestive of amyloidosis. So, you can, okay, first of all, the diagnosis of this clinical scenario is restrictive cardiomyopathy. So how can you tell that this is a case of restrictive cardiomyopathy? Patients with restrictive cardiomyopathy, they have the features of both right and as well as left heart failure. So shortness of breath, it is a feature of the left heart failure, right? And elevated JVP, it is a feature of the right heart failure. And the JVP is getting worse with inspiration. That means it is the Kussmaul sign. Kussmaul sign is seen in the restrictive cardiomyopathy. And pedal edema, it is a feature of your right heart failure. And laboratory studies are normal, but biopsy if you have done, that is showing you apple green birefringence with Congo red staining, which is characteristic of your amyloidosis. So among the options given to you, right, which particular gene mutation will cause amyloidosis resulting in restrictive cardiomyopathy? That will be your transthyretin. So the answer is B, that is transthyretin. Now you see the next clinical scenario. A 35-year-old male with no past medical history presents with increasing shortness of breath and dyspnea on exertion, lower extremity edema increasing over the past month. His temperature is 37 degrees centigrade and blood pressure 90/60, heart rate 100, respiration 20 and oxygen saturation 95% on the room air. Physical examination reveals decreased breath sounds at the left base without wheezing, elevated JVP markedly worse with inspiration, 2+ lower extremity pitting edema. Laboratory studies are normal. Which of the following is not the etiology for the clinical condition? Scleroderma, hemochromatosis, carcinoid syndrome, and then the Wilson's disease. So, what is this clinical scenario suggestive of? This particular clinical scenario, it is suggestive of the restrictive cardiomyopathy. This particular clinical scenario is suggestive of restrictive cardiomyopathy. And scleroderma, yes, it will cause restrictive cardiomyopathy. Hemochromatosis will cause restrictive cardiomyopathy. Carcinoid syndrome also will cause restrictive cardiomyopathy, but not Wilson's. So Wilson's, it is not the etiology for the development of restrictive cardiomyopathy. And this Wilson's disease, it is a disorder which is characterized by excessive accumulation of copper in the body. And these patients with Wilson's, they develop macronodular cirrhosis. So, if you see the next important clinical scenario, we have a 24-year male patient presents with gastrointestinal symptoms such as abdominal cramping, frequent bowel movements, diarrhea and early satiety, reduced appetite, nausea or vomiting and increased shortness of breath, dyspnea on exertion and decreased urine output. Blood pressure is 90/60, physical examination revealed decreased breath sounds at the left base without wheezing, elevated JVP markedly worse with inspiration and 2+ lower extremity pitting edema. What is the enzymatic defect for this particular clinical condition? So, if you see this clinical scenario, like multiple system involvement is there. So, there is involvement of the GIT, that is in the form of abdominal cramping, frequent bowel movements, diarrhea and early satiety, and there is also nausea, vomiting. And there is also involvement of the kidney. And that involvement of the kidney, it is in the form of the decrease in the urine output. And there is also involvement of the respiratory system, right? That is by decreased breath sounds at the left base without wheezing. And there is also dyspnea as well. And there is also involvement of the cardiovascular system, that is elevated JVP is there and lower extremity pitting edema is there. So it is the disorder with multiple system involvement. And even if you take the JVP, what is happening? The JVP is getting elevated with inspiration. So what is this suggestive of? This is suggestive of the Kussmaul sign, right? So it is the disorder with the diagnosis of the restrictive cardiomyopathy. And you need to know what is that particular enzymatic defect that can make the individual to develop the restrictive cardiomyopathy. So along with the cardiac manifestations, there are also multiple systems which are being affected. So in restrictive cardiomyopathy, or the etiology of restrictive cardiomyopathy where you have multiple system involvement, is the Fabry's disease, right, which is a lysosomal storage disorder in which the enzyme which is being defective or deficient is alpha galactosidase A deficiency, right? So the answer is A. Then what about the other options, right? If you take the hexosaminidase A, hexosaminidase A enzymatic defect is present in the Tay-Sachs disease. And in Tay-Sachs, there is only involvement of the brain and as well as retina. And you take this sphingomyelinase. Sphingomyelinase is the enzymatic defect seen in patients with the Niemann-Pick's disease. And in Niemann-Pick's disease, brain, liver and as well as spleen is affected, but there is no cardiac involvement. Then you take galactosyl ceramidase enzyme. This galactosyl ceramidase enzyme, it is defective or deficient in Krebs disease. So in Krebs disease, the enzyme that is being accumulated is galactocerebroside, right? It is galactocerebroside, and the tissue which is involved is the brain, right? The tissue which is involved is the brain. So let me just show you this particular table, and our particular disorder in the clinical scenario is the Fabry's disease, right, where there is alpha galactosidase A deficiency, where there is involvement of skin, there is involvement of the kidney, there is also involvement of the GAT, there is also involvement of the brain, and there is also involvement of the heart, where in Fabry's disease. Whereas the other enzymatic deficiencies like hexosaminidase A, Tay-Sachs, right, and the other option like what we had was sphingomyelinase, that is Niemann-Pick's disease, and another important enzyme deficiency is galactosyl ceramidase, and that particular disorder is the Graves' disease. Okay, so these are the tissues which are involved, enzymatic defects and the accumulated substances, right, and our clinical scenario is suggestive of the Fabry's disease where there is alpha galactosidase A deficiency. Now I'll show you one more question. What is the antibody in this condition causing the restrictive cardiomyopathy? Anti-Smith, anti-centromere, anti-topoisomerase, anti-dsDNA. So now if you observe this female, right, the skin over the face, right, the skin over the face, it is completely tight, and even if you see the mouth, right, it is like microstomia, right, the individual is unable to open the mouth completely, right, so the individual has, you can observe that here, a puckered skin, right, so you will have that in patients with, or this facial appearance or this skin appearance will be there in patients with the scleroderma. And in patients with scleroderma, what is the antibody that will be your anti-topoisomerase, right? So we have two types of scleroderma. One is localized scleroderma and as well as the diffuse scleroderma. And in case of diffuse scleroderma, you have the development of the restrictive cardiomyopathy. And in diffuse scleroderma, the antibody is anti-topoisomerase. Whereas in localized scleroderma, the visual organ involvement is very rare. And in localized scleroderma, the antibody is anti-centromere antibody. But the question is saying that there is presence of restrictive cardiomyopathy. That means there is visual organ involvement that is seen in diffuse scleroderma. And in diffuse scleroderma, the antibody is the anti-centromere antibody. Now, you see the next question. What is the adverse effect of the drug used for the treatment of the following condition causing the restrictive cardiomyopathy? So, if you observe the chest X-ray over there, what is that you are seeing? You are observing the presence of bilateral hilar lymphadenopathy. Right, bilateral hilar lymphadenopathy. So, this bilateral, right, so this bilateral hilar lymphadenopathy, this is seen in patients with sarcoidosis. Right, this is seen in patients with the sarcoidosis. Okay, so in patients with sarcoidosis, there is presence of a non-caseating granuloma. And what will be the drug of choice for this particular patients with sarcoidosis? That will be the steroids. Right, that will be the steroids. And this particular steroids, what are the adverse effects? Steroids can cause the peptic ulcers. The weight loss will not be there with the steroids. Excessive steroid supplementation will make the individual to land up in the iatrogenic Cushing's, and in Cushing's there will be weight gain, there will not be weight loss, and they will not have distal muscle weakness in Cushing's, there will be proximal muscle weakness in Cushing's, and dementia is also not seen. So what is the adverse effect of the drug used for the treatment of the following condition causing restrictive cardiomyopathy? That is the peptic ulcers. So actually, the clinical diagnosis is sarcoidosis. For sarcoidosis, the drug of choice is steroids. The steroids will cause the peptic, right? Next. What is a parasite that is associated with restrictive cardiomyopathy? Ankylostoma duodenale, schistosoma, hematobium, ascaris lumbricoides, plasmodium, falciparum. So please remember, it is your ascaris, the roundworm, which is responsible for the development of restrictive cardiomyopathy. Next. Which of the following is a cause for restrictive cardiomyopathy? Alcohol, hemochromatosis, amyloidosis, sarcoidosis. We have just now discussed this question, that is the amyloidosis. Now, After having discussed about the etiology of restrictive cardiomyopathy, you need to know what exactly is the pathophysiology of restrictive cardiomyopathy and what are the clinical features of the restrictive cardiomyopathy. So, you see the question, false regarding the restrictive cardiomyopathy. Filling pressure is increased, left ventricular hypertrophy is seen, heart failure is not predominantly right-sided. In early phase, the systolic function is not impaired. So, the question is, what is the false statement? Right? Let me discuss the pathophysiology and clinical manifestations and then come back to this question at the end of the discussion. So if you take the pathophysiology of restrictive cardiomyopathy, it is a disease where the heart muscle becomes stiff. Right? It is the disease where the heart muscles, it becomes stiff. Right? And this causes the pressure within the ventricles to rise precipitously with small increase in volume. So, when the heart muscles become stiff, the ventricles, they are unable to relax. Right? Ventricles, they are unable to relax. Okay. So, there is right. So, there is diastolic dysfunction. Right? These patients have diastolic dysfunction. So, because there is diastolic dysfunction, they cannot fill at normal diastolic pressure. Right? So, the pressure within the ventricles, they precipitously increase with small increase in volume. Right? Pressure in the ventricles increases with small increase in volume. Right? With small increase in volume. Okay? Right? So, if you see the heart in these individuals with restrictive cardiomyopathy, the walls, they become stiff. Because the walls, they become stiff, the ventricles, they are unable to relax. Okay? Now, what will happen? There will be reduced filling of the ventricles. Right? There will be reduced filling of the ventricles. Because there is reduced filling of the ventricles, this will eventually lead to low cardiac output. Right? So, because of this, there is low cardiac output. And what will happen to pressures within the atria? So, pressures within the atria increases both in the right and as well as the left atrium. So, increased filling pressures, they cause elevation of the pressure in the venous side and elevation of the pressure on the pulmonary veins as well. So, because of increase in the right atrial pressure, right, there will be also increase in systemic venous pressure. Right, there will be also increase in the systemic venous pressure. And because of increase in because of increase in the left atrial pressure, there will be pulmonary congestion. Right, there will be pulmonary congestion. Okay, why? Because once there is increase in left atrial pressure, there will be increase in pulmonary venous pressure. There will be increase in pulmonary capillary wedge pressure, and that will result in the pulmonary edema. Right, that will result in the development of the pulmonary edema. Okay, now you have to understand that in patients with restrictive cardiomyopathy, right heart failure, that is more predominant than compared to that of the left heart failure. Okay, right heart failure is more predominant than the left heart failure. Now the question is why? So, why the patients, they have predominant right heart failure symptoms rather than the left heart failure symptoms. So if you see the thickness of myocardium, right, if you see the thickness of the myocardium, the left side myocardium or left heart, it is more thick than compared to that of the right heart. Okay, left-sided myocardium thickness is more than right-sided myocardium. So, in case of restrictive cardiomyopathy, majority of the manifestations are mainly because of the infiltration, right? The etiology of restrictive cardiomyopathy is mainly the infiltrative pathologies, like you take amyloidosis or you take sarcoidosis or you take radiation, mainly infiltrative pathologies. So, the right side of the heart, okay, right side of the heart, it is thin compared to that of the left side of the heart. So whenever there is infiltrative pathology causing restrictive cardiomyopathy, the right side of the heart is affected first, then compared to that of left side of the heart, because the right side heart thickness is less than compared to that of the left side. So that is the reason why, so these infiltrative pathologies, they affect the right side of the heart. So accordingly, what will be the manifestations, right? So they'll have the features of right-sided heart failure. So there will be raised JVP, right? And there will be tender hepatomegaly, right? And there will be also, right? There will be also the presence of the pedal edema, right? And there will be also development of ascites. So these are the manifestations of the right-sided heart failure. Then followed by that, the chest pain. So chest pain is also another important feature of this restrictive cardiomyopathy, mainly secondary to this amyloidosis, right? If the etiology of restrictive cardiomyopathy, right, if the etiology of restrictive cardiomyopathy is the amyloidosis, these individuals can also have the development of the chest pain. So chest pain secondary to angina or chest pain mimicking myocardial ischemia can be observed, and it is primarily seen in patients with the amyloidosis. Okay, and why is that? Because of the accumulation of amyloid material within the myocardium, the myocardial compression of these coronary arteries can occur. So once there is myocardial compression of these particular coronary arteries, the blood supply to the myocardium will be reduced, resulting in myocardial ischemia, and thereby the individual will have chest pain. So this particular chest pain is due to myocardial compression, right? It is due to myocardial compression of the small vessels by the amyloid material, and that will cause myocardial ischemia, causing the angina or chest pain. And these patients, they may also complain of the palpitations. See, why they develop palpitations, I'll explain you. Right, these patients, they also complain of the palpitations, and these palpitations are mainly because of or secondary to atrial fibrillation. Now, let me explain you why there will be development of atrial arrhythmias in these individuals. So, if you observe the heart in restrictive cardiomyopathy, the atria, they are dilated, right? The atria, they are dilated because the atrial pressures are increased. So these enlarged atria, they will be throwing or showering abnormal impulses. So once these abnormal impulses are showered from the distended atria, the individual will land up in what is called atrial fibrillation, and because of the atrial fibrillation, the patient will present to you with the history of palpitations. Now, apart from that, these individuals, they also develop the thromboembolic complications. These individuals will also develop thromboembolic complications, right? So, as many as 1/3 of patients with idiopathic restrictive cardiomyopathy may present with the thromboembolic complications. So, almost 1/3 of patients with restrictive cardiomyopathy, right, almost 1/3 of patients with restrictive cardiomyopathy, they may present with the thromboembolic complications, right? And what will be this particular thromboembolic complications? See, why is this thromboembolic complications? First of all, because these patients, they are presenting with atrial fibrillation, and whenever there is development of atrial fibrillation, there will be stasis of the blood within the atria. Because of the stasis of the blood within the atria, there will be thrombus formation, and this particular thrombus can shower an emboli. So that will lead to a thromboembolic complications. So, right, so thromboembolic and this particular thromboembolic complications, it could be either left side. So, if the thromboembolic complications is mainly because of the thrombus formation within the left side, the individual will have the systemic emboli which is being present. Right, the systemic emboli is present. Okay, if there is left atrial thrombus, or if there is left atrial clots, if there is right atrial clots, right, if there is right atrial clots, then the individual will develop the pulmonary emboli. Right, the individual will develop pulmonary emboli. So that will be the clinical manifestations secondary to your thromboembolic complications. Either there can be systemic embolization, or there could be the pulmonary embolization. Then, now after having discussed about the clinical manifestations, let me discuss about what will be the features on examination in patients with restrictive cardiomyopathy. So on examination, first you need to examine the JVP. So what will happen to the JVP in these patients with the restrictive cardiomyopathy? JVP, it is increased, right? Increased venous pressure is reflected in the increased jugular venous pulse, and the degree of elevation of jugular venous pressure indicates the severity of impaired filling of the right ventricle. Okay, so the degree of elevation is directly proportional to, right, it is directly proportional to severity of the right heart failure. And in these patients with the restrictive cardiomyopathy, you also have the abnormalities within the waves. And the abnormalities in the waves that you will observe is, there will be rapid X and as well as Y descent. Okay, and why is this rapid X and Y descent? X wave is due to atrial relaxation. Y descent is due to atrial emptying. Both these changes are mainly because of increase in the atrial pressures, right? And if you take even this particular Y wave, the individual will not only have the rapid Y descent, and it is also a prominent Y descent. Right, the individual will also have a prominent Y descent. Then followed by that, these patients, they also have the Kussmaul sign. So what is this Kussmaul sign? Increase in the jugular venous volume on inspiration, right? Increase in the jugular venous volume on inspiration is called Kussmaul sign. In a normal individual, on inspiration, the jugular venous volume decreases. But in restrictive cardiomyopathy, in patients with constrictive pericarditis, in patients with tricuspid regurgitation, in patients with tricuspid stenosis, in patients with right heart failure, the jugular venous volume increases on inspiration, and that is what is called as the Kussmaul sign. So, Kussmaul sign is a characteristic feature in patients with restrictive cardiomyopathy. And the other point is, these individuals, they have a low volume pulse. So, why do you think that they have low volume pulse? Because the cardiac output is reduced. So, that is the reason why the volume of the pulse, it will be a low volume pulse. Then, coming to the auscultation in these patients with the restrictive cardiomyopathy. See, first heart sound and second heart sound, it will be normal, S1 and S2. Right, so this will be more or less normal in patients with restrictive cardiomyopathy, and even second heart sound, the split, if you see, they have normal S2 split. And followed by that, if you take the additional sounds, these patients with restrictive cardiomyopathy, a loud early diastolic filling sound may be heard, right? So that loud early diastolic filling sound, right? So this loud early diastolic filling sound, this is nothing but your S3, right? This S3 may be present, but it is uncommon or it is rare in case of amyloidosis. And please remember S4, right? S4, it is never present. Right? S4, it is never present. Okay? And why is that? Possibly secondary to amyloid infiltration of the atria. Okay? Why it is not present? That is due to right, that is due to amyloid infiltration of the atria. Okay, so the fourth heart sound is never present. Actually, fourth heart sound is due to atrial contraction, that is second rapid filling, and here atria does not contract. Why? Because of the amyloid infiltration. And because of increase in the filling pressures of the ventricles, the atria, they are dilated. When the atria are dilated, even the valves, the mitral valve and tricuspid valve, they are being stretched apart. So, because the valves, they are stretched apart, these individuals, they have murmurs. Right? These individuals, they have the murmurs of mitral regurgitation and the tricuspid regurgitation. And this will be the functional murmurs. Right, this will be the functional murmurs. That is what you will hear on auscultation in patients with the restrictive cardiomyopathy. Then, followed by that, how will you diagnose these patients with the restrictive cardiomyopathy? That is by chest X-ray. Right, that is by chest X-ray. There are various methods. Actually, the investigation of choice or first line investigation will be the 2D echo. Right, what will be the first line investigation? Right, the first line investigation is the two-dimensional echocardiography, right? And what will the X-ray show? X-ray will show you the presence of mild cardiomegaly, right? And apart from that, because of increase in left atrial pressure, you will notice the presence of the pulmonary congestion. Right, you will notice the presence of pulmonary congestion. Then followed by that, the other important investigation is ECG. So, what does the ECG shows? ECG in patients with the restrictive cardiomyopathy will show you the presence of the low voltage complexes. Now, what do you understand by this word, the low voltage complexes? Low voltage complexes is that where the amplitude of QRS complexes will be less than 10 mm in chest leads and the amplitude of the QRS complexes will be less than 5 mm in limb leads. Okay, so this is what is the definition of the low voltage complexes, and that is what you will see in patients with the restrictive cardiomyopathy. And the first line investigation will be your 2D echo, right? And what does the 2D echo shows? The echocardiogram, it reveals small thickened left ventricle with bright myocardium. So if you take the ventricles, right, they are thickened, and if you take the lumen of the ventricles, they have the small lumen, and if you take the myocardium, they have bright myocardium. And this myocardium, it is speckled. Right, this myocardium, it is speckled, okay, and the speckled myocardium, you know, it is very much suggestive of the amyloidosis. And in the Doppler studies, you will observe that there will be rapid early diastolic filling. Right, there will be rapid early diastolic filling, and that is being revealed by mitral inflow Doppler studies. Right, so this is what you will observe in the Doppler studies. And if you take the atria, you will observe the presence of biatrial enlargement. Right, you will observe the presence of the biatrial enlargement. That is what the 2D echo shows in patients with the restrictive cardiomyopathy. And the LV chamber size, that is also reduced. And these patients with the restrictive cardiomyopathy, we have discussed that the individual is having diastolic dysfunction. So they will have the development of heart failure with preserved ejection fraction. So that we call it as HFpEF. Right, and even if you observe the atria, the atrial septal thickening may also be evident. Right, the atrial septal thickening is also evident. That is what you will observe in the echocardiogram. And that speckled pattern, it is a characteristic myocardial texture in amyloidosis, right? And there will be thickening of all cardiac structures. Then coming to the biopsy. See, biopsy, what are the sites from which the biopsy you have to take in these patients is the rectal, abdominal fat or gingival biopsy. That will confirm the presence of the systemic involvement. Okay, rectal, abdominal fat, or the gingival biopsy. Okay, so these particular biopsies will confirm the systemic involvement. Alright, but myocardial involvement may still be present if these are negative and requires the endomyocardial biopsy. Actually, if this involvement is there, that tells you that there is systemic involvement of your amyloidosis. Even if these biopsies are negative, right, even if these biopsies are negative, you require to do an endomyocardial biopsy. Right, you require to do an endomyocardial biopsy. So this endomyocardial biopsy will confirm the presence of, right, this endomyocardial biopsy will confirm the presence of the cardiac amyloidosis. Right, will confirm the presence of the cardiac amyloidosis. And this particular biopsy specimen, you have to observe or you have to visualize with a special stain, right? And with the special stain, if you visualize, you will be able to define that specific abnormal protein under the microscopy. Okay, so this is about your biopsy. So when you do this endomyocardial biopsy is useful to determine the underlying etiology. Right, to determine the etiology for the development of the restrictive cardiomyopathy. Right, so to determine the etiology, endomyocardial biopsy will be the investigation of choice in case of restrictive cardiomyopathy. Now, you see the next question. What is the etiology of the following condition causing restrictive cardiomyopathy? Thymine deficiency, sarcoidosis, amyloidosis, and then the scleroderma. So, if you see that particular 2D echo image, what is that you are able to make out? The presence of the speckled pattern, right? The presence of tiny dots, that is called speckled pattern, which is seen in patients with the amyloidosis, right? Which is seen in patients with amyloidosis. Next question. Which particular blood test can help differentiate or distinguish between restrictive cardiomyopathy and the constrictive pericarditis? Brain natriuretic peptide levels, troponin I, ANP level, and CKMB. Let me tell you, it is the brain natriuretic peptide levels. In constrictive pericarditis, BNP levels, they are normal. Right, brain natriuretic peptide levels, they are normal. Okay, but there may be minimal elevation in case of the restrictive cardiomyopathy. In case of restrictive cardiomyopathy, there is minimal elevation. So, minimal elevation of the brain natriuretic peptide levels will be there in patients with the restrictive cardiomyopathy. Right, and in constrictive pericarditis, the scarred pericardium prohibits the wall stretch and thus the levels are low. So why do you think that the brain natriuretic peptide levels are normal or low in constrictive pericarditis? Because the pericardium, it is scarred. Right, because the pericardium, it is scarred. So this will prohibit the wall stretch. Right, this will prohibit the wall stretch. When will you think that, or when do you think that the brain natriuretic peptide is released? When there is stretch of the ventricle, then the brain natriuretic peptide will be released into the circulation. In restrictive cardiomyopathy, the walls indeed, they stretch. Right, the walls indeed, they stretch, and thereby there will be release of brain natriuretic peptide into the circulation, and there will be increase in the BNP levels within the blood. That is what will happen in patients with the restrictive cardiomyopathy. So this will be the 2D echo image in patients with restrictive cardiomyopathy. You can observe, see, this will be your right atrium and this will be your left atrium. The atria, they are enlarged, and ventricle lumen size or the chamber size will be reduced because of reduced filling. And the another important investigation is the cardiac MRI. So even cardiac MRI will be able to make out like how are the chambers and if there is any infiltrative pathologies present in the restrictive cardiomyopathy. Next, then coming to the treatment. See, first and foremost, the very important group of drugs that you have to give in acute cases will be diuretics. See, this diuretics, when you give in acute cases, right, this diuretics, when you give in acute cases, it will help in relieving the pulmonary edema, right? So it will relieve, right, it will relieve the systemic edema. So what do you mean by the word systemic edema? That is, the pedal edema will be relieved, right? Ascites will be reduced, okay? And not only that, there will be also reduction in the pulmonary edema as well. Right, there will be also reduction in the pulmonary edema as well. So that is about the role of diuretic. And anticoagulants, they are also very much required in patients with restrictive cardiomyopathy. See, these patients, when they develop atrial fibrillation, there is chance of the thrombus formation. And this particular thrombus can shower an emboli. So to prevent the thromboembolic complications, the anticoagulation is very much required. And the next important question is, can we use digoxin in restrictive cardiomyopathy? Let me tell you, digoxin in restrictive cardiomyopathy should not be used. Right? And the question is why? Because digoxin in restrictive cardiomyopathy may precipitate the arrhythmias. Right, it may precipitate the arrhythmias, and that is the reason why it should not be used. Then what about the beta blockers and calcium channel blockers? Beta blockers, what they can do is they will reduce the heart rate and improve the filling by increasing the diastolic time. So these beta blockers, they reduce the heart rate. So by reducing the heart rate, what will happen to the diastolic time? There will be increase in the diastolic time. Right. So because of increase in the diastolic time, there will be improvement in filling of the cardiac chambers. Right, there is improvement in filling of the cardiac chambers. Okay, so that is what will happen whenever you give beta blockers. So beta blockers, they will slow the heart rate and improve the filling by increasing the diastolic time. And you take the calcium channel blockers. When you take, like for example, non-dihydropyridine type of calcium channel blockers, the example of what we have is verapamil. So verapamil, it presumably works by improving the myocardial relaxation and increasing the diastolic filling time. So even verapamil will also increase right, even verapamil will also increase the diastolic filling time. Okay, so in these patients with the restrictive cardiomyopathy, slow heart rates are desired, that is mainly to allow for increased diastolic filling time. Right, so that is about the role of the beta blockers and as well as the calcium channel blockers. Then ACE inhibitors or the angiotensin II receptor blockers. The ACE inhibitors or angiotensin receptor blockers may improve the diastolic filling at times and can be tried with caution if the systemic blood pressure is adequate. So what it will do? They will improve the diastolic filling. Right, they will improve the diastolic filling at times, and these can be tried with caution if the systemic blood pressure is adequate. Right, if the systemic blood pressure is adequate. Then is there any role of the corticosteroids? See, corticosteroids may be helpful in sarcoidosis. Right, for example, if the sarcoidosis, right, if sarcoidosis is the cause for restrictive cardiomyopathy, corticosteroids may be helpful in sarcoidosis, but they are more effective for conduction abnormalities than heart failure. Okay, so they are more effective for conduction abnormalities. Right, they are more effective for conduction abnormalities than compared to that of the heart failure. Then next, coming to the heart transplantation. See, initially you need to try with the medical management. So medical management, if the individual is refractory, right, or the individual is not responsive to medical management, then heart transplantation should be done. So heart transplantation is done in patients refractory to medical management. Right, should be done in patients who are refractory to medical management. So that is about your heart transplantation. So if we see some questions now, false statement regarding restrictive cardiomyopathy is filling pressure is increased. Yes, this is a true statement. Filling pressure is increased. Left ventricular hypertrophy will be there. Yes, this is also a true statement. Both biventricular hypertrophy will be there. And heart failure is not predominantly right-sided. That is a wrong statement. Right, the question is which is a false statement. So the heart failure is not predominantly right-sided, this will be a false statement. Heart failure is predominantly right-sided in these individuals, and I have also explained you the reason as well. Next question, in early phase, next option, in early phase, the systolic function is not impaired. This is also a true statement. So these individuals actually they have heart failure with preserved ejection fraction, that is HFpEF. Later, as the disease progresses, there will be heart failure with reduced ejection fraction, that is HFrEF. Okay, so this is about the false statement regarding the restrictive cardiomyopathy. Next, you see another question. A 42-year-old male with no past cardiovascular medical history comes to the emergency department with complaining of shortness of breath and lower extremity edema for 1 month. He is afebrile with a heart rate of 160 beats per minute, respiratory rate 20 per minute, and the blood pressure is 140 by 90 millimeters of mercury and oxygen saturation 92% on room air. His jugular venous pressure is markedly elevated. Lung examination reveals diffuse RALs. A 2/6 systolic ejection murmur is appreciated at the right upper sternal border. S3 heart sound is present and the point of maximal impulse is laterally displaced. S4 is not heard. There is 3+ pitting edema up to the knee. ECG confirms the atrial fibrillation with an uncontrolled ventricular rate. In 2D echo, it is suggestive of restrictive cardiomyopathy. What is the most appropriate initial management? So, finally the diagnosis is there for you with the help of a 2D echo, and whatever has been explained to you in the beginning of this clinical scenario are the features of both right and as well as left heart failure. And these individuals, they are also having functional murmurs, right? The 2/6 systolic ejection murmur, whatever is being heard is a functional murmur. So, what will be the initial management in restrictive cardiomyopathy? Intravenous amiodarone, intravenous ibutylite, intravenous diltiazem or metoprolol, intravenous digoxin. So, in these patients, they are in a state of the atrial fibrillation. So, you need to reduce the ventricular rate, for which you need to give the diltiazem or the metoprolol. That will be the first line management. Okay, so once you reduce the heart rate, that will improve the diastolic filling time, and that will increase the diastolic filling, and the individual will become the hemodynamically stable. And after that, right, after that you can convert the patient into the sinus rhythm. So converting his rhythm to sinus, that will not be the initial approach. Right, it is not the initial approach in hemodynamically stable patient. Hemodynamically stable patient, right, first you control the heart rate and then followed by that you convert the rhythm to sinus. Okay, and digoxin alone is generally not recommended to lower the heart rate in atrial fibrillation in patients with the restrictive cardiomyopathy, right? And one more question. Yes, so these are some of the important points related to your restrictive cardiomyopathy, in which I have discussed the most common cause to be amyloidosis, right? And in these individuals, right heart failure is predominantly seen, and in order to relieve the pulmonary congestion and systemic congestion, you need to give diuretics, and the very important group of drugs are beta blockers. So with this, I'll wind up this session on the topic of restrictive cardiomyopathy. Thank you very much.